Dr. Ashkanazi, thank you very much. I appreciate that. That's a very novel concept. And I think what we'll do here is we're going to go ahead and engage in the conversation. We'll start up with the panel. I hope everybody can hear us now. I'd like to start with a question to pose to everybody. Dr. Ashkanazi has presented this concept of the bystander and empowering the bystander. How do you respond to that, Dr. Jacobs?
Well, I think he's absolutely right. We have citizen CPR. We have the Heimlich maneuver. You wouldn't, if you saw somebody choking in a restaurant, you don't watch them turn blue, you do something. And so the concept of citizen first responder, I think, is exactly on target. The training for that, both the American College of Surgeons and the American College of Emergency Physicians have developed citizen education, which is obviously basic, but it does cause you to stop hemorrhage and open an airway. Because I think Dr. Ashkanazi is exactly right. Those are the people who are there on scene. And certainly in Boston, that was very clear that the first responder, or the citizen, was the first responder.
Well, I think Boston's a unique situation because they had a lot of pre-hospital pre-positioning of equipment, personnel, had a trauma center tent set up. So, you know, I think personally, Boston was fantastic. Don't get me wrong. I just think that it was unique. The preparation proved that we can get a better outcome. But David, Dr. Tuggle, when you look back at the experience that you had, do you think we are making progress with bystander education in the United States?
I think that it's much better than it used to be. And I think that the one thing is that it's going to happen. You cannot prevent the bystanders from helping because that's just our nature worldwide, not just in the United States. So I think this idea of offering brief training for those who are interested would be very useful.
Dr. Knudson, what are your thoughts about it after you saw what happened there in San Francisco?
Actually, the heroes in this case were the flight attendants who really did take care of the patients before they took care of themselves and made sure they got off the plane. The plane did start on fire eventually, but everybody was off the plane by that time. I would just caution that you don't want to have bystanders get injured, though. And I think Len Jacobs would probably agree that the teachers in that school, although they helped to save lives, I mean, they were also at risk. So we have to be a little bit careful with that recommendation.
I have a question. So I don't know what's the data on this, Isaac. I feel like the reason that bystanders, and it's what we just sort of heard, the reason bystanders don't get involved is that they're afraid there's going to be a second explosion. They're going to get hurt.
No.
What is the data? Because at Boston...
The data in the United States is that first responders arrive to the area and they take the bystanders out. This is the mission. This is a crime scene. Immediately the bystanders are out. There is a distrust between, for the first responders, the bystanders are not immediate responders. They are victims. They should be out or on the ground. They can't be helpers. So we should protect the bystanders with good Samaritan law, but good, not Samaritan law that is not protecting. And we should encourage them to be in the field while the first responders are arriving, and they can help. The first responders should command them and tell them what to do, and they can save lives. In any case, they will save lives. They are not going to listen. They will save lives, but if we will prepare them, they will save lives much better. I'm not afraid that one bystander or two bystanders will be injured. So what? This is part of being a community. You should help each other.
Yeah. Well, Dr. Jacobs, are you still with us there?
I am, yes.
What are your thoughts here along this line that you're pushing the idea from the Hartford consensus that there ought to be more proactive intervention by the bystanders, and yet at the same time, Dr. Ponsky is saying that a lot of these people are going to be afraid to go in because of the second incident that might come on. How are we going to get around that?
Well, you know, I think that there's a modicum of truth in all of this. The real reality is that people want to be helpful. And I think what was demonstrated in Boston, which The reason that it's demonstrated is it happened in the middle of the day, and there was a lot of media there. So you saw people getting involved and helping. People ran towards the victims to be helpful, and they stopped bleeding. They didn't run away. So I think what we need to do is recognize that, teach them what to do, provide them with equipment, etc., which is useful. For instance, in our malls, we have, and in public places, automatic external defibrillators. We need to have bleeding control bags with hemostatic dressings and tourniquets right beside them. And in fact, we have in our hospital, so that it does two things. It empowers the person to get involved, but it also, as Dr. Ashkanazi says, it says, you've hurt us, but you have not terrorized us. We have confidence in the government, in the system, and we will help ourselves. But we have to give them both the philosophy and the tools to empower the first responder. But I also agree with what Peggy said. It is risky, it's scary, but and what I've seen is that the public is big-hearted and they really do want to help.
So, Dr. Knudson, do you agree with what Dr. Jacobs is saying here, that we ought to actually have everybody buy a tourniquet, carry it with them, or have it available in a public space to stop bleeding?
You know, I wanted to mention how much we've learned in the last 10 years of war from our military colleagues. Those tourniquets certainly in Boston saved lives, and we've put them in our pre-hospital, in the hands of our pre-hospital people here in San Francisco, and back into our emergency room where we threw them out before. We also learned about mass casualties and how to handle them because of what has been seen in the war zone. So I wanted to give the recognition for our military for how much they've taught us, and these disasters show that we've listened and tried to learn from them. I think tourniquets are amazing. Boston was interesting as we looked at some of the tourniquets. They were whatever they could get, belts, all kinds of stuff, and I think that they have reassessed that from talking to Dr. Velmahos about where the tourniquets are in the pre-hospital arena in Boston now. So I was on call last night, by the way, in case I look a little beat up, and a guy came in with the tourniquet appropriately, and he's still got his leg this morning, so I'm pleased to say that.
Well, that's fantastic. Maybe we've got a few more minutes here, and I might want to pose this question to you.
I'm going to, before you pose your question, I want to, Stefan, if you could put the call-in number at the bottom of the screen again. We want to encourage the audience. Feel free, if you have a question, call it in, and we can put you on the air, and we can ask your questions. We want everyone here to have a voice. The whole purpose is to get everyone giving their thoughts together. Don't just let us talk. We want to hear what everyone else has to say. So
and blog in, too.
Write your chat questions. We'll put them on the air. That's the whole point of this. Don't be shy.
Yeah, we got 20, 30 countries. Tell us what you're thinking, because I know in Brazil they recently had a big disaster with a burn where over 200 people really died because of the fact that there were no smoke detectors in the facility. So there are a lot of people all over the world that have this problem. But one of the things to sort of end up this discussion, maybe each of you could tell us what's the one thing that you would recommend our colleagues around the world think about when it comes down to actually responding to a disaster. What would be the first thing? It's almost like just in time. If I called Dr. Tuggle and say, David, you've been through this, what are the 3 things I need to know? What would you say, David?
I would say that take your drills seriously. A lot of people will try to do something else, but take the drills seriously. I think that this concept of the bystander as the first responder is something that you should employ in your community and see how it works for you, because this sort of response is a lot like a politician once said, all immediate mass casualty care is local. It takes a while to mobilize outside help, so you're going to have to take care of it yourself. Yes. And for children especially, you need to think about reunification and how to do that, and be aware that that's something that needs to be planned for.
Dr. Knudson, what are your thoughts?
Well, the first thought I have is, despite all the preparation that you might think you have, when it actually happens, it's very different than the way you practiced it. And I think the most important thing initially is to maintain some semblance of calmness. Just remind people we do this every day, maybe not to this extent, but go with what you know and take care of the issues as best you can. The idea of calling people in and having enough bodies, it's just the opposite. You're going to get a lot of people who come in and want to help, and you have to learn how to manage those people as well as the people that you do actually need. And I think the third thing is what we forget is these things go on for hours, days, and months. Long after the media goes home, you're still taking care of these patients. You still have to pay attention to those patients who have been in this disaster, both their physical and their psychological needs. And when you have an international disaster, a challenge for us was dealing with the different cultures of how much we could say, what these families needed, and we certainly learned a lot from that.
Excellent. Dr. Jacobs?
Well, I have a saying, when it's getting complex, you want to get simple. And I believe in starting at the beginning.
Great
so
line.
really, in the very first seconds, you do need to have an empowered, both philosophically and educationally and technically, first responder team. Citizens. Second, need good organization. So police, fire, EMS, there must be one boss. Somebody must be in charge. They all have to talk the same language, and they all have to do what is planned to do. And then third, the hospital has to be totally linked to that. We're not an island. We're not a citizen state here. Everybody has to be in this thing together, and we have to practice it together, and practice for real, not in some sort of tabletop exercise, but do it for real in a place, in a mall, in a civic center, somewhere where you get the touch and feel and the logistics and difficulty in making all of this happen. And I think if we do that, when something bad happens, which unfortunately I think it will, we'll be better prepared and have better survival.
So, Dr. Ashkanazi, you've introduced this bystander concept now. What would you tell somebody?
I will give you my 3 recommendations first.
Please do.
The first recommendation is that if you are drilling, don't be generous to each other. Be critic, because this is the only chance to improve your systems.
During a drill.
During your drill.
Yeah.
Second, learn from others' mistakes. There are many mass casualties around the world, and we are doing many mistakes. So instead of waiting for your mistakes and your chance to make mistakes, please learn from our mistakes, and you will be better. And third, involve the bystanders. This is a paradigm. Involve the bystanders not only in the response but also in the preparedness. They should feel that they are acknowledged as part of the preparedness. This is my message.
Okay, this is what we do now when it gets short on time. We're going to do some rapid fire, okay? So we have a lot of questions. Is that okay with you, sir?
Yeah,
We have time?
We do have
so
time.
don't go too fast. Okay, because we got questions and I want to make sure we get to stuff. I'm going to start at the back first. So this was a question that was very interesting. Jody Coffey, and again, I may not say your question well enough, so it's best if you call in, but I'm going to read Jody's comment here, and it's a very interesting one. In the United States and other countries that have federal privacy laws, are there exemptions from these laws in mass casualties? So is there an exemption from federal privacy laws in mass casualties, and how does this impact the reunification strategies utilizing the internet and social media? So when it comes to mass casualties, are there exceptions? Does anyone know out there what happens with the privacy laws, or how do we get information, and what is the impact of that, and are there exceptions? So,
Dr. Knudson?
We had to deal with that. As I mentioned in my talk, we could not get the manifest from the plane. The only people that can get the manifest, it turns out, is the Red Cross. So we had a huge amount of difficulty identifying patients, trying to match them up with their families. Most of them did not speak English. So this was a huge issue, and we learned a lot from that. The second thing was that, as I started to say, the differences in what you can release about patients is very different from country to country. And even though we were completely HIPAA compliant with what we said to the media, many of these families interpreted us as saying things that were too general, and also that they could identify patients by what we said, which certainly wasn't true or wasn't meant to be true. So there's different international policies, and this was a learning experience for us. But go to the Red Cross when it comes to identifying people, because they're the only people that can help you at that time. Until the Homeland Security and the customs people came in to help us out with identification, we actually had some patients we didn't identify for several days.
Dr. Jacobs, do you have any idea about, is there a repository someplace on a website where you can go and find out what those guidelines are?
I don't know the answer to that, but I do know that there are federal laws and there are state laws. The general sort of overarch is the Good Samaritan law, which gives you a fair amount of protection, both as a citizen and as a licensed provider, if you're doing the right thing in an emergency and are demonstrated to be doing that. I do not know any federal, I just don't know the federal law, but I know state laws are fairly decent about that in terms of Good Samaritan protection.
Dr. Tuggle, you have any thoughts?
I'm fairly certain that a mass casualty event is not an exemption to HIPAA. So I mean, if someone else knows better than I do, I would say that. But when they've made regulations similar to this, such as Medicare, et cetera, they do not make any exception for mass casualty events unless those laws are suspended, federal laws are suspended, and that just depends on the situation.
So it's important.
I would say that for the U.S.
So it's important to be aware of that. Dr. Ashkanazi?
We have decided after 10 years, 3 weeks ago, we established a center in Israel that will deal with disasters and regulations. There is a problem. We evaluated the Samaritan law in United States, and it is not protecting enough. The Good Samaritan law is not good enough.
For bystanders to respond.
For bystanders. I'm talking about bystanders. It is not encouraging, it is not keeping safe the bystander. We evaluated it from many angles, and lawyers have told us it is not protecting enough. We need something better.
Yeah, we actually, and Rosen Nelson, you just wrote a lot there. Can you please call in? I'd rather you just talk on the air instead of typing that. So please call in. We want to hear what you say.
Or the faculty should respond to that after we go off, because we only have about 3 or 4 minutes to go.
So I saw this conversation going on, and Kevin, are you there?
Hi, Kevin Chung speaking.
Kevin, thanks. So Kevin Chung is in the United States Army Institute of Surgical Research. He's a faculty later on, but he's been responding, and I wanted to get some insight. Keisha Fraser-Doe says, why decontamination after a plane crash? What chemicals are we supposed to be worried about? Or is this just some silly precaution? And then Kevin went on to answer, and I said, Kevin, get on the air and tell us what's going on. So can you explain to us what you were talking about? And then I want to know what Peggy's thoughts are, too.
Yeah, and Kevin, be concise.
So fire suppression systems exist in all aircraft. We've experienced this in the military, land vehicles, and whenever there's an explosion, that triggers that automated fire suppression system, and that has all sorts of chemicals. One we've experienced is hydrogen fluoride, which it's an asphyxiant, and patients come in with inhalation injury. In high heat, that turns into hydrogen fluoride, and you get the typical hydrogen fluoride burn, which can be lethal.
Is that hydrofluoric acid?
That's it.
Fluoric acid, correct. So the hydrogen fluoride is the gaseous form, and then the hydrofluoric acid is the liquid form, which occurs when, in high heat.
So do we need to decontaminate the patient from that?
I'm not sure what type of decontamination is necessary for that. I've only seen these patients in the hospital. They are profoundly hypocalcemic, and we need to reverse them with intravenous calcium. Other than that, I suppose washing them off. I don't know if anybody else has any experience with airplane crashes.
How about topical calcium and calcium gels and stuff that you do like for fluoride burns?
Dr.
Correct.
Knudson?
So for small burns, that's good. For hydrogen fluoride, when it's when you inhale it, they present with severe inhalation injury, and I don't think anybody knows if inhaled calcium really works. That's what people do, but I don't know if anybody else has any experience with that.
Dr. Knudson, do you have a thought?
The two people that were almost all the patients that we got had some degree of this hypocalcemia, but the two that were the worst had these open burns, and we wondered if they absorbed it because they were actually the sickest. So they didn't have the inhalation that we would have expected, although one little girl probably did, and that contributed to her death. It's interesting you should say that, Kevin, because that's the only thing we could find on a tox screen was the hydrogen fluoride, and we didn't know how to explain it. And I tried to talk to all of the firefighters. I talked to Boeing. I talked to the FAA, and they didn't come up with hydrogen fluoride. So you've actually solved the problem for us. We did wash down these patients that were burned like we would normally treat a burn. We didn't realize initially that we were dealing with road burn. But probably we postulated that they might have absorbed some of it in there through these open wounds, and that's why they were so sick.
For the sake of time, I want to go on. So we have a commenter on the phone. Is it Nelson?
Nelson?
Yeah.
Nelson, is it Rosen?
Yeah, Nelson Rosen at Cohen Children's.
From where?
Nelson Rosen, yes.
Yeah, where are you from, Nelson?
Cohen Children's in New York.
Cohen Children's. Thanks for calling in. Can you go ahead and more clearly explain what you were commenting on there?
Yeah, hi. I've been a combat surgeon in the Army Reserve for now 20 years, and one of the things that, just to emphasize the validity of Dr. Ashkanazi's point, is that we really, in addition to tourniquets, which is a great lesson from the past decade, we really picked up on this concept of CASEVAC, which is exactly what we're talking about, bystander care, where, it's a force multiplier. Every human out there, we try to get them trained with some basic first aid. It's a combat lifesaver course. It's not for medical people. It's just, they get a little extra stuff in a little bag that they carry, and then they are able to provide buddy aid. There's usually a medic out there with ground units, but that medic can't be everywhere at every time. But the buddy can, and when they scoop them up, they get them into the hospital as quick as possible. And if you wait for medevac, you'll lose patients. And that lesson is probably, for disaster management, the most important thing to come out of the past 10 years, perhaps even more important than tourniquets save lives.
It's a great...
Dr. Rosen, you just summarized the whole thing.
Thank you.
That was great. See, this is why we want you to call in. We want you to call in because this is what makes it fun. And then we're gonna let you close it out. I did want to say that if someone could comment just to show you, Jody, if someone you can look at what Jody was asking more, and Dr. Jacobs more about, can families find out where their family members have gone? If someone could chat that in and answer Jody's comment or question about that. But I think that was a fantastic session. I'm going to turn things over to you.
Outstanding. The faculty was outstanding, and please do chat with the people out there, because you'll go on for 15, 20, 30 minutes. Answering their questions, so please do that.
Also, by the way, we can put polls up, so if there's someone in the audience that's curious about what everyone else is doing, ask us and we can put your poll up for you.
Yeah. So we're going to move on now.